Hi everybody, and welcome to our module on hypertension in pregnancy. Hypertension in pregnancy is potentially dangerous to the mother and the baby, so let's start by talking about how we categorize hypertension that occurs during pregnancy. If hypertension is detected prior to pregnancy or early in the pregnancy before 20 weeks, that type of hypertension is called pre-existing or chronic hypertension. Basically, women who have high blood pressure identified at their first prenatal visit when they're only a few weeks along, those women had hypertension before they became pregnant, they just didn't know it. So this is not considered pregnancy-related hypertension. Gestational hypertension is hypertension that occurs after 20 weeks, and this is a form of hypertension that is associated with the pregnancy. And then finally, preeclampsia and eclampsia are unique and dangerous forms of hypertension in pregnancy, where in addition to high blood pressure, women develop proteinuria and end organ damage, and we'll talk about this more as we go along in this video. First, let's talk about gestational hypertension. The definition is elevated blood pressure that occurs after 20 weeks of pregnancy with no protein in the urine and no other evidence of preeclampsia. And just by way of review, there are a number of drugs that are safe in pregnancy. I talk about these in more detail in the cardiology video on hypertension drugs, but alpha-methyl-dopa is a safe drug in pregnancy, as is labetalol, which is a beta-1, beta-2, alpha-1 blocker. Also, you can use in pregnancy nifedipine, which is a calcium channel blocker. Now let's talk about preeclampsia. You can basically think of preeclampsia as a special form of hypertension in pregnancy that involves multiple different organ systems. It's a multi-system disorder of pregnancy. It involves hypertension and also protein in the urine and also end organ dysfunction. And we'll talk about all these things in more detail in the next few slides. First, let's talk about why women who are pregnant develop preeclampsia. This is a disorder of the placenta. Normally, the trophoblast invades the uterus and transforms the spiral arteries. If this invasion and transformation is abnormal, that leads to preeclampsia. What happens is the spiral arteries do not develop normally, and therefore the placenta is underperfused. When the placenta does not get enough blood flow, this leads to the release of circulating substances that travel through the mother's body. This leads to diffuse maternal endothelial dysfunction, and in particular, it can lead to vasospasm in coagulation, and this is why lots of different organ systems become involved. And importantly, this is all a disorder of the placenta, so it goes away with delivery. When the placenta is removed, there will be no more preeclampsia. Here's a picture from the web to make this more clear. When a woman is not pregnant, what happens is shown in the slide on the left. The spiral arteries grow into the endometrium during the normal course of the menstrual cycle. When a woman becomes pregnant, what happens is extravillous trophoblastic tissue. Those are these blue cells shown here. These are trophoblast cells, but they're not part of the chorionic villi. These are extravillous cells. They grow down through the decidua and into the myometrium, and they alter the spiral arteries. The spiral arteries become larger and more tortuous, and they're able to deliver lots of blood into the decidua and into the chorionic villi. In preeclampsia, what happens is shown on the right side of the screen. The trophoblastic cells fail to invade all the way into the myometrium. As a result, the spiral arteries do not get altered, and they are unable to deliver sufficient blood to the placenta. So I've summarized these points here. In preeclampsia, extravillous trophoblast cells fail to penetrate the myometrium. As a result, the spiral arteries do not develop normally in pregnancy. They remain narrow, and this results in placental hypoperfusion. Now, in the early stages of pregnancy, when the baby is small and the placenta is small, this may not be a problem, but it becomes a big problem in the later stages when the placenta and the baby need lots of blood flow. And we'll talk about this on the next slide, but usually preeclampsia develops in the third trimester. And the reason for that is because that's the point in time when this underperfusion of the placenta by those narrow spiral arteries becomes a major problem. And this can result in ischemia to the placenta. And for that reason, the classic finding if you biopsy the placenta is to see fibrinoid necrosis of blood vessels. This is an example of fibrinoid necrosis shown on the screen here. It's a special type of necrosis where this pink material accumulates in the wall of blood vessels, and that is what is seen in women who have preeclampsia, and it's caused by ischemia and underperfusion of the placenta because the spiral arteries are not normal. Now let's talk about the clinical features of preeclampsia. Usually this disorder occurs in the third trimester, often very close to the time of delivery. The classic presentation is new onset of hypertension in a mother with no known hypertension who is having her first pregnancy. Preeclampsia can occur on top of pre-existing hypertension, but the classic presentation for a board question is to be in a woman who has no history of hypertension. Also, the first pregnancy, as we'll talk about in a minute, is a higher risk pregnancy. Women who have had one prior pregnancy without preeclampsia are at lower risk. And then in addition to hypertension, there needs to be either protein in the urine or evidence of end organ damage. End organ damage means evidence of damage to an organ from decreased blood flow and high blood pressure. So this might include renal failure. Renal failure can occur from vasospasm of renal vessels. It can include a number of CNS problems from poor blood flow. This could be a headache or visual changes or confusion. And then finally, we'll talk more about this in a minute, this may also include liver failure. Now, when I was in medical school, I was taught that the classic triad of preeclampsia is hypertension, proteinuria, and edema. Edema has been de-emphasized in guidelines because many pregnant women have edema for reasons other than preeclampsia. But I think it's still helpful to remember this classic triad because in a board question, this is the way preeclampsia will often be described. And the reason it will often be described that way is because many women with preeclampsia present with lower extremity pitting edema, as is shown in this picture here. This type of edema can develop for a number of reasons. First of all, in preeclampsia, there is endothelial dysfunction, so fluid can leak out of the vascular space. There's also protein loss in the urine, so this can lead to a low oncotic pressure, and that can also allow fluid to leak out of the vascular space. And any time fluid is lost from the vascular system, the kidneys respond by retaining salt and water. So all three of these elements can conspire to lead to lower extremity pitting edema in women who have preeclampsia. Preeclampsia also often involves the liver. There can be edema of the liver via any of the mechanisms we just described. There can also be poor blood flow to the liver that can lead to ischemia and necrosis. And for this reason, elevated liver function tests are common in women who have preeclampsia. Shown on the screen are some of the risk factors for preeclampsia. So if a woman has had preeclampsia during one pregnancy, she's at higher risk to have it again during the next one. Also, the first pregnancy is a higher risk pregnancy, as I mentioned before. The classic presentation is a woman who is having her first pregnancy. Once a woman has had one normal pregnancy with no preeclampsia, she is at lower risk. If there's a family history of preeclampsia, the risk is higher. And then finally, women who are having twins or triplets or any form of multiple gestation pregnancy are at increased risk. There are a number of maternal conditions that a woman may have prior to pregnancy that increase her risk of preeclampsia. These include diabetes, hypertension, obesity, and any form of chronic kidney disease. And then finally, women who have lupus and the antiphospholipid syndrome are at high risk of preeclampsia. Now, women with lupus and the antiphospholipid syndrome often have repeated miscarriages, but if they are able to carry a baby into the third trimester, then they become at higher risk for preeclampsia. So the reason preeclampsia is such a dangerous disorder is because there are a number of complications that can happen to the baby and the mother. In terms of the baby, the major problem is that there's placental insufficiency. So there's poor blood flow to the placenta because those spiral arteries are not properly developed. So the baby can have growth restriction and there can be oligohydramnios. And then sometimes the poor perfusion can lead to a placental abruption. There are also a number of complications that can occur in the mother. First of all, the mother can develop pulmonary edema. All those mechanisms of capillary leak that we talked about for lower extremity edema can also occur in the pulmonary capillaries, and this can lead to pulmonary edema. The mother can also develop heart failure. The high blood pressure can cause the left ventricle to fail. The liver can develop a hematoma, and this can potentially rupture, and then all that ischemia and necrosis we talked about before can lead to liver failure. Disseminated intravascular coagulation may occur, stroke can occur, and women can potentially end up on dialysis from advanced renal failure. So that's preeclampsia. Now let's talk about eclampsia. Eclampsia is seizures that occurs in a mother with preeclampsia. So years ago, it was noticed that a small percentage of pregnant women would develop seizures, and that disorder was called eclampsia. It was then noticed that before they developed seizures, they would have high blood pressure and protein in their urine, and that was called preeclampsia. That's how these disorders got their names. The type of seizures that usually occur in preeclampsia are generalized tonic-clonic seizures. This can lead to coma and death. It's a very serious disorder in pregnancy. The eclampsia is often complicated by DIC and respiratory failure, and these women usually end up in the intensive care unit. The exact etiology of the seizures is unclear, but it's likely related to abnormal blood flow and endothelial dysfunction, just like the rest of the pathogenesis of preeclampsia. The anticonvulsant of choice in eclampsia is magnesium sulfate. This is a very unusual drug to use to treat seizures. Often benzodiazepines and other drugs are used. They can sometimes be used in eclampsia, but the drug of choice is magnesium. That's because it's the most effective drug. And in fact, it's often given for prevention in women who have preeclampsia. So if a woman's got high blood pressure and protein in her urine and she meets the criteria for preeclampsia, she'll be started on magnesium sulfate to limit the chance that she will develop seizures. The definitive treatment, however, for both preeclampsia and eclampsia is to deliver the baby. As I told you before, these disorders are caused by the placenta, and when you remove the placenta, they go away. So if the onset of these disorders is late in pregnancy, close to when the baby is viable, the baby will often just be delivered to eliminate the preeclampsia and eclampsia. Finally, I'll talk about the HELP syndrome, which is a variant of preeclampsia. Each of the letters HELLP stand for an element of the syndrome. The H is for hemolysis, the EL is for elevated liver enzymes, the LP is for low platelet count, and this is a complication of preeclampsia. You can basically think of it as a severe form. It's caused by coagulation activation and liver infarction. Now, as we talked about before, there can be some coagulation activation and liver infarction in many forms of preeclampsia, but if it progresses to cause hemolysis and severe liver damage, then it is called the HELP syndrome. And the type of hemolysis seen in the HELP syndrome is a microangiopathic hemolytic anemia. I talk about this more in the hematology section, but by way of review, in this disorder, you will see schistocytes on peripheral blood smear, like is shown in this picture here. The bilirubin level will be up and the haptoglobin level will be low, and the platelet count will also be low due to consumption of platelets. And once again, best treatment is to deliver the baby if you can, because that takes away the placenta, which is the source of the problem. And that concludes our video on hypertension in pregnancy.